This is Dr. Phillips. I will be speaking on cellular regulation with the exemplars of brain tumor, laryngeal carcinoma, and malignant melanoma. This is Dr. Phillips. I will be talking today on cellular regulation with the exemplars being brain tumor, laryngeal carcinoma, and malignant melanoma. In this slide, it shows different types of brain tumors that can occur. Meningiomas are the most common types of brain tumors, and the most common sites are shown here in this slide. Meningiomas can grow in different places. Technically, it arises in the meninges, and if the meningioma grows or causes swelling that presses against the brain or other structures in the skull, it can cause a brain tumor symptoms. The slide on the left shows different types of brain tumors, the most common being meningiomas. Meningiomas can grow in different places, technically arising in the meninges. If it grows or causes swelling that presses against the brain or other structures in the skull, it can cause brain tumor symptoms. Meningioma symptoms depend on their size and the location. Meningioma presents with the typical brain tumor symptoms such as a headache, vision problems, or seizures. A headache, even a severe one on its own, is seldom a symptom of a meningioma or any other type of brain tumor. A meningioma diagnosis may occur when the doctor is looking for something else totally different. For instance, you might be having migraine headaches, and they'll do a scan, and the meningioma will show up. So like I previously said, meningiomas are the most common benign intracranial tumor and can grow in different places. The diagnosis, like I said, may occur when the doctor is looking for something else. Most meningiomas do not spread. They're usually benign, can grow quietly for years without causing any problems or symptoms, and they can get surprisingly large as well. As far as surgery, do you do surgery or not? Well, it depends on where is it located. The main treatment for meningiomas is surgery to remove it through a craniotomy or any other type of procedure. It's all about the location. Other slow-growing tumors are usually benign tumors are pituitary tumors and acoustic neuromas, also known as schwannomas. Your gliomas, medulloblastomas, your neuroectodermal tumors, your germ cell tumors, and the craniopharyngeal tumors are the ones that are malignant. Brain tumor diagnoses usually is often incidental. That is, the doctor discovers a tumor on a CT or an MRI while examining the individual, like I said, for another reason, such as a head injury or another neurological problem. Meningiomas are the most common type of brain tumor, like I said before, and they're usually benign. To do surgery or not, it depends on the location. If surgery is done, it's usually through a craniotomy or some other type of procedure. Other slow-growing and usually benign tumors are pituitary tumors and acoustic neuromas, also known as schwannomas. Gliomas, medulloblastomas, neuroectodermal tumors, and germ cell tumors, and craniopharyngiomas are usually the ones that are malignant. Brain tumors diagnoses are often, like I said, incidental. That is, the doctor will discover a tumor on a CT or an MRI while they're examining the individual for another reason, such as a head injury or another neurological problem. Some of the signs and symptoms are headaches, memory loss, seizure, nausea and vomiting, vision changes, poor decisions, weakness of a limb or limbs, loss of sensation, and loss of one of the senses: smell, taste, vision, hearing, and balance. Personality changes can also occur, as well as language changes. I'm sure you've heard of people that have come out of had brain surgery and they start speaking in another language. It's fascinating. Glioblastomas are your most common malignant primary brain tumors, and with these type of tumors, there's a rapid onset of symptoms, unlike meningiomas. Gliomas, as well as meningiomas, can develop in the brain tissue, but brain tumors can also metastasize from other sites. Breast and lung cancer commonly shows mets to the brain as a secondary site. Rarely does a headache without any other symptom indicate a brain tumor. Oftentimes, if the tumor is on the pituitary gland or displaces it, we will see the symptoms in the other organs of the pituitary effects. As you can see in the slide, such as the skin, adrenal cortex, the breasts, the kidneys, ovaries, testicles, thyroids, muscles, etc. A transsphenoidal hypophyseectomy is the procedure that is done when a pituitary gland is confined to the sella turcica, and the doctor will go in through right underneath the nasal area and the upper lip, and they can enter the sella turcica to remove the tumor. Brain tumors can arise anywhere within the brain structure. Primary tumors originate within the central nervous system and rarely metastasize. The secondary brain tumors result from metastasis, like I said before, such as the breast and the lung. The tumors expand and invade and infiltrates, compressing and displacing brain tissue. And of course, the result can lead to cerebral edema, brain tissue inflammation, increased intracranial pressure, neurological defects, hydrocephalus, or pituitary dysfunction. Interventions depend on the type, size, and location of the tumor. Malignant tumors, which may be managed by chemotherapy, radiation, and/or surgery. Stereotactic radiosurgery is an alternative to traditional surgery and may include modified linear acceleration using accelerated X-rays, or using beams of protons and isotope seeds implanted in the tumor. The goal, of course, is to decrease the tumor size no matter what type of treatment they're having done, intervention, and the goal is not only to decrease the tumor size, but it's also to improve the quality of life and improve survival time. The goal of surgery is maximum resection. With chemotherapy, it can be administered by numerous routes. It can be administered orally, intravenously. And the goal with chemotherapy is to kill as many possible cancer cells as possible. With chemotherapy, it'll help to shrink the tumor before radiation, although it can be effective before and after radiation, as it will destroy all remaining cancer cells after the surgery. So sometimes they'll do chemotherapy before, then they'll do radiation, and then they'll do chemo again. With chemotherapy, it will destroy all remaining cancer cells after the surgery. So they'll go ahead and do the surgery and then do chemotherapy again. The immune system will not kill the cancer cells with chemotherapy. Only chemotherapy can kill cancer cells, not your immune system. Radiation and chemo may be done for patients where surgery is not a viable option due to severe comorbidities. Radiation typically is done 5 times a week for up to 6 weeks. With radiation, it's a localized treatment. It may precede the surgery to shrink the tumor first, and then they'll do surgery. It may follow surgery to kill cancer cells left behind. It may also be used, like I said, in palliation as palliative care for inoperable cancers. Just recently, we had a terminally ill patient that had cancer, and the doctor was suggesting to have radiation therapy as palliative care to ease their symptoms. Temolizumab chemotherapy usually is given during and after radiation. This type of chemotherapy does not have a negative effect on the quality of life. Also, anti-epileptics are given to address the seizures, and steroids to address the inflammation. Some of the labs that you may be looking at, of course, would be your white blood cells, of course, your WBCs, but also your serum albumin and your serum creatinine. When a patient is scheduled for craniotomy, of course, there are certain interventions that need to be done prior to and post-operatively. The nurse needs to get a baseline exam, which includes a full neuro exam, which of course includes the mental status, the cranial nerve, motor, sensory, and cerebellum exam, psychosocial, and informed consent. When I say psychosocial, it's you need to assess not only their psychosocial status and emotions, but also their families prior to having it done. Get a baseline on that. You really need to assess the emotional reactions of not only the patient but the reactions of the family members to the brain cancer diagnosis, and help them cope by providing them with information and referrals for support systems if needed. You will also make sure that they have an informed consent sign. Usually an isotonic solution of IV fluids will be hung. Blood pressure control will be on board prior to the surgery. Corticosteroids, anticonvulsants pre and post-op, antibiotics, DVT prophylaxis, and imaging if needed. Post-operatively, you will maintain head and neck in a neutral position, supine with head of the bed elevated 30 degrees. You want to avoid hypo or hypertension. You want to monitor their electrolytes, their strict INOs, make sure that they're urinating. I also do weights, closely monitoring with hourly neuro checks, pain control, ice pack for the edema. So when they come out of surgery, you will be applying an ice pack to the surgical incision, incentive spirometer, Q2 hours, and you want to avoid hyper or hypoglycemia. So you have to have tight glycemic control. The incision will be open to air after the first 24 hours. And you want to maintain the O2 sats at 94% or greater. Any flexion or extension of the head or neck can cause edema to the airway and or increase intracranial pressure. So, like I said, you want to keep them neutral. Never lay them flat or Trendelenburg. If the patient does not have a bone flap in place, do not put any pressure on the side of the head. As stated previously, position is important. Usually the head of the bed is 30 degrees, semi-Fowler's position. You must assess the gag reflex before any PO intake. If the patient cannot swallow small sips of water without coughing, drooling, or inability to speak after swallowing, they failed the swallow study and need speech therapy to evaluate. Assessing the blood pressure, hypertension can cause hemorrhage to the surgical site and cerebral edema. Increased ICP. Low blood pressure can cause hypoperfusion and ischemia. Watch for hypovolemic shock. As far as the GI ulcers are common, so you want to make sure they have a PPI and or H2 blockers on board. Endocrine disturbances can occur if the pituitary area was worked on, such as DI or SIADH. So you want to be looking at those signs and symptoms. You want to assess for meningitis. Signs and symptoms would be a fever, a headache, nuchal rigidity, photophobia, petechiae rash to torso and lower extremities. You also want to assess for a brain abscess. If there's a brain abscess, it will need to be drained, and they should be on some type of antibiotic therapy. Pain control, absolutely no NSAIDs for risk of platelet disruption or hemorrhage. It's hard to balance a neuro exam with pain control. Short-acting pain agents preferably are preferred, especially what can be reversed easily. You want to avoid sedation if at all possible. If a patient has a drain, never place it on suction, only to gravity. No incentive spirometer use if there is a transsphenoidal surgery due to a pituitary tumor. You want to teach them to avoid blowing their nose. They may have nasal packing in place. O2 only orally, nothing over the nose. Like I said previously, strict glucose control. Most patients are on steroids, so they will normally go up even if they're not a diabetic. Monitor any drainage from the ears and or nose. Test for glucose to see if the CSF is involved. Like I said, avoid hypotonic IV fluids or any IV fluids that contain dextrose. So you're going to be using isotonic or hypertonic only if required, but it's usually isotonic. Okay, now we're going to talk about plan of care for chemotherapy and radiation. Chemotherapy side effects may include bone marrow suppression, nausea and vomiting, mucositis, alopecia, changes in cognitive function, and peripheral neuropathies. Your assessment priorities. If they have a venous access device, not a central line, but a venous access peripheral site, and they're getting chemotherapy, you must be assessing that venous access every 30 to 60 minutes during chemotherapy. Chemotherapy is caustic to the veins, and it can cause them to lose a limb. The oral mucosa of patients with neutropenia should be assessed at least every 8 hours. You want to report any temperature over 100.4 in a patient with neutropenia. So with someone that has neutropenia, you would want to be taking their temperature, Q4 and PRN, if their temp is 100.4 or greater. With radiation therapy, the biggest thing is assessing the skin exposure to radiation. Okay, as part of your assessment, of course, you'll be taking routine vital signs as needed. You'll be taking the temp, Q4 hours and PRN if there is a temperature present, 100.4 or greater. You're going to be assessing for active bleeding. Remember, these patients are immunocompromised. You want to keep the O2 sats at 94% or greater. If not, then you'd want to provide them oxygen. Your nursing interventions, you're going to be assessing for signs and symptoms of anemia and thrombocytopenia. Your diagnostic tests and labs, you need to know your labs. You need to know your normal values for H&H, your CBCs, your platelets, your WBCs, and your calcium. Nutritional considerations. So a lot of these patients may experience anorexia cachexia, which is a loss of weight and muscle mass from the effects of chemo and radiation, or just the effects of cancer. Decrease in serum protein levels, they may experience a decrease in serum protein levels because they're not eating. They also may experience alteration to taste. They may also have a food aversion. They may not want something like red meat, a coffee, a chocolate. Hydration. You need to keep them hydrated. They need to. They don't want to eat. They don't feel like eating, so you need to offer them small, frequent meals, bland foods, soft foods, and cold foods if preferred. Your lab serum protein level, which is normal value, is 6.0 to 8.0 grams per deciliter. So if it falls below that range, you need to be looking at them nutritionally. Your glucose levels, cancer can cause an increase in glucose levels as the tumor secretes substances that will affect the glucose levels. Pharmacological measures, of course, you may want to give them something, an antiemetic, or like I said before, PPI, H2 blocker. Also, an anti-seizure medication if they are experiencing seizures. Patient and family teaching. One of the things you must teach them is to have a calm environment, okay? If there is a family member that's coming to visit, assess that situation. It may, even though the patient loves that family member, the family member may actually cause undue stress. And of course, you want to have measurable patient outcomes. Do their care in measurable increments. In other words, make their outcomes, make their goals in small increments. Don't lay everything on them at one time. Okay, oncological emergencies can occur. They may result from the cancer itself or may occur as a side effect of the treatment. Metabolic emergencies, there are three types. There's tumor lysis syndrome, septic shock, and hypercalcemia. With tumor lysis syndrome, it's a metabolic imbalance. It occurs as a result of high tumor cell kill. It results in rapid release of normal intracellular products, causing hyperkalemia. hyperuricemia, and hyperphosphatemia. It can result in cardiac arrhythmias, renal failure, and death. With septic shock, the immune suppression causes higher risk for infection. With hypercalcemia, this is the most common metabolic complication of malignancies. It occurs when the rate of calcium mobilization from the bone exceeds the renal threshold for calcium excretion. The standard therapy is vigorous hydration and normal saline and furosemide. That's when you need to be looking at your calcium levels. The other type of oncological emergency is a hematological emergency. This is a result from bone marrow suppression or from hyperleukocytosis. The bone marrow suppression results in anemia and thrombocytopenia. There may be idiopathic bleeding, and they may experience DIC. There's also space-occupying lesions. That's when there's extensive tumor growth, which can cause spinal cord compression, ICP, brain herniation, seizures, GI obstruction, cardiac respiratory complications, and superior vena cava syndrome. So these are all types of oncological emergencies. All right, moving on to laryngeal cancer. The laryngeal cancer comprises half of all head and neck cancers. Squamous cell carcinoma is the most prevalent. The most common signs and symptoms are sore throat, ear pain, hoarseness, coughing, pain with swallowing, dyspnea, lump or mass in the neck. Hoarseness and voice change is a common early sign. Stridor is usually a later sign seen with this type of cancer. Smoking plus alcohol increases the risk even more. African American males greater than 60 years old are the most affected. Any issues above the glottis will pose aspirate precautions. Cancer affecting the larynx is almost always a primary tumor. Standard therapy for laryngeal cancer is surgery, laryngectomy. It will depend on the site and the stage of the cancer. Radiation combined with chemotherapy. Usually the chemotherapy is cisplatin, and F5U is the most common. Chemo alone with radiation is not very beneficial. Usually it's both. F5U is fluorouracil is the most common type of chemotherapy used. The most common side effects can cause stomatitis, mucositis, esophagitis, nausea and vomiting, and diarrhea. So if any of these occur, you need to let the oncologist know as soon as they start, because they can get into trouble really quickly. It can also cause chest pain, and you need to call 911 if they start having chest pain with this type of chemotherapy. Cisplatin is the other chemotherapy that's commonly used for laryngeal cancer. It's an alkylating agent. The most common side effects are nausea and vomiting and diarrhea. Cisplatin can cause neuropathies, especially in the hands and the feet. Xerostoma and stomatitis it will also cause. So you need to rinse the mouth with warm salt water and baking soda to soothe the mouth. Oral care is huge with these type of chemotherapies. They'll need multidisciplinary care, social services, speech, physical therapy, occupational therapy, and respiratory therapy, dietitians, etc. Everybody needs to be on board. They need to stay hydrated. The patient needs to use things like Biotine mouth rinse to keep the mucosa wet because they get severe dry mouth. Cisplatin will also cause neutropenia, so you need to avoid infections. So oral care is a big thing when they're receiving these types of chemotherapy because they can get into infections real quick with the oral mucosa and stomatitis and xerostoma. Okay, so post-op care for radical head and neck surgery, of course, is to maintain an patent airway. And you will be providing them with humidified air or O2. Of course, you want to assess their GCS and their level of consciousness. You want to make sure that they're NPO. If they're NPO, they're okay for enteral feedings. Stoma care. You need to make sure that you are caring for assessing that stoma, Q-shift, and PRN if needed. Trachea suction, Q4 and PRN. If you, I strongly suggest that you review your clinical skills on trachea so that you know how to properly care for these patients. They will need communication aids. Once PO feeding can be started, thickened liquids only. Teaching. Apply any type of neck resection will affect the arm and the shoulder muscles because they're weakened. All that area has been manipulated and they will need extensive physical therapy. You need to teach them to cough out the secretions. There'll be a neck breather, so because they're going to have they may have a tracheotomy, and so no swimming, of course. If they are allowed to take a shower somewhere down the line, they must turn their back to the shower head. You need to teach them how to remove the tube, Q4 to 6 hours, and clean it with sterile saline and peroxide mixture. Clean the stoma site. Don't let any fluid get into the stoma, and use a Q-tip for cleaning around it. Suction is needed, and it may be often because these are fresh post-ops and they'll have copious secretions. Humidified air and O2. Remember that their normal process of filtration and humidification is now bypassed, so they produce, like I said, a lot of mucus. So they need to have humidified air or oxygen. They need to keep their secretions moist, and they can use a bedside humidifier at home. They can have a stoma without a trach. Because they are neck breathers, if CPR is done, ventilation is through the stoma. All right, let's talk about skin cancer. The leading cause of skin cancer is sun exposure and tanning beds. Age, skin type, skin color, and genetic predispositions all play a part in skin cancer. Risk factors: a single blistering sunburn during childhood or adolescence more than doubles a child's risk for developing melanoma in later years. Environmental factors: UV radiation, pollutants, chemicals, ionizing radiation, viruses, and physical trauma can also cause skin cancer. You do not have to be out in the sun to develop a melanoma. prevention, safe sun practice, avoid staying out in direct sunlight from 11 a.m. to 3 p.m. is the most damaging. However, down south, it may be, you might hear them say between 10 and 4. Between 10 and 4, usually down south where we live, because we have so much sun, direct sunlight, is usually a more adequate time for safe sun practice. Daily use of sunscreen, SPF of greater than 15, although it's preferred 30 SPF or greater. You need to apply 30 minutes before exposure, and you need to reapply every 2 hours. Light color clothing, hats, long sleeves, and sunglasses. Now they're making clothes with protection in them. If you're going out, if you're swimming or excessively sweating, you need to immediately reapply the sunscreen after swimming or excessive sweating. Preferred sunglasses with UV protection to prevent burning of the cornea or the lens. And that's not just UV, it's UVA and UVB. Remember that as we age, we are at higher risk for sun cancer because we have had longer exposure to the sun than someone that's a lot younger. Okay, classifications of skin cancers. There's melanoma and non-melanoma. Melanoma is the malignant type of skin cancer. It arises from the melanocytes. These are cells that are located at or near the basal layer. It's the deepest epidermal layer. Malignant melanomas can develop wherever there is pigment. However, approximately a third originate from moles. Prognosis for melanomas depends on several variables. There's precursor lesions. There is congenital nevi. These are moles that are present at birth. There is dysplastic nevi. These are the atypical moles. Normal moles during childhood have a greater increase in abnormal development after puberty. Then you've got the lentigo maligna, also known as Hutchinson freckle. This is a tan or black patch that looks like a freckle. It grows slowly, dark, thick, nodular. Usually seen on one side of the face of an older adult who has had large amounts of sun exposure. And in the next slide, I have pictures of that. In addition to the lentigo malignant melanoma, and as you can see how it can progress, it gets nodular. And I have actually seen this on a patient. There's also acral lentiginous. This is rare, okay, but it is ill-defined dark brown blue black macule, okay? It arises on the palms or the soles of the feet and subungual skin. It's usually present in dark skin individuals. As you can see in these pictures, the one on the thumb to the left side, it looks like they have slammed their finger in a door, but that's actually cancer. Also, if you look down at the bottom at the heel, it looks like a blood blister, but it's not. In fact, I know someone that had that. And he went to the physician, and it was indeed acral lentiginous. So this is why it's so important to do your physical assessments, not just chest and lungs, but the head to toe, front to back. When you're doing your physical assessment, you're checking head to toe for other moles. So if someone comes in for their physical examination and you're doing it, and you see something suspicious, the first thing you're going to want to do is assess for other moles. So you will assess for other moles head to toe. That's your physical assessment. Then when you're interviewing them, you'll ask them if there's a family history or of any moles. Do they have any other moles or warts or birthmarks that itch? A birthmark that itches can be a malignant mole. Does the mole or the lesion have a crust? Does it bleed? It can be caused from tan. Do you tan? Or use a tanning bed, etc. That's part of your interviewing of the patient. You want to teach them to get regular checkups every 3 months for the first 2 years if they've had a malignant melanoma. They need to get checked every 3 months for the first 2 years, and then every 6 months for the next 5 years, and then yearly after that. That's the usual MO for checkups. The ABC method, I'm sure you've heard of this. This is how you are going to assess moles. Okay, A stands for asymmetry. Okay, as you can see, a regular mole is symmetrical. When it starts to become asymmetrical, that's when you would suspect a malignancy. B is the border. Are the borders regular? Are they poorly defined? C is the color. Is it a normal color, or has it changed from like a light brown to a darker brown or a black? It's changed in color. These are also questions you can ask them. Diameter, usually greater than 6 millimeters, is a concern. So what is the size of that lesion? Is it less than 6 millimeters, or is it greater than 6 millimeters? And E, is it evolving in size and color and thickness? That's the ABCDE method of detecting melanomas. And everyone should get a full body examination from the dermatologist. And when I say full body, that means from the scalp all the way down to the toenails and in between the gluteal folds and the butt crack. There are lesions that can be hidden that your dermatologist will look for, okay? This is the end of my lecture. If you need to have any clarification, please go on the discussion board and I will answer any questions or clear up any muddy areas.